Good morning and welcome. And I wanted to start this by acknowledging the traditional owners of the land on which we meet. I'm meeting with you all on the Mooka land out here at Redland Bay. But if you want to put into the chat or the Q&A where you're from, we can acknowledge that, the broad sweep. We just want to put some context around what we're doing and why this is so important. Many of you know that we at the Red Rose Foundation have specialised our work in working with victims of non-lethal strangulation. This work for us has evolved over more than 20 years. It started with myself doing a Churchill Fellowship over in the US and had the privilege to meet with Gail Strack, Casey Gwynn and Bill Smock in San Diego and the rest of their team. And I've been over now to their place and done extensive training, and others associated with the Red Rose Foundation have as well. But we thought our work was going to involve in getting a standalone strangulation piece of legislation in the criminal code and at the same time getting a Queensland Domestic Violence Death Review Board. We achieved both of those in 2016 under Not Now, Not Ever. But after that, our work was far from over. We started to step out and do training on strangulation and other forms of high risk. But the women started to come to us. And to this day, the majority of our referrals are still self-referrals, where women are coming to us through social media, us talking at events, etc. We also get referrals from police, hospitals and other places. The more we do this work, the more we realise brain injury is real, particularly the anoxic brain injury associated with strangulation. But so is acquired brain injury, with women reporting getting thrown downstairs, banged against walls as they're strangled. We've also learned that strangulation is not a one-off event. It's complex and victims are often strangled multiple times. This often doesn't get recognised by service providers. We also are recognising more and more that while the majority of strangulation victims may not have visible injuries, they have internal injuries, and often those injuries can impact on their life in a very serious way, through strokes, through blood clots through their body, into their lungs, but more importantly, through brain injury. And while we started the trauma centre and our counsellors are all trauma trained, not just informed, trauma trained counsellors, we realise there are women that it goes beyond the trauma, that they have a brain injury, and the way that that impacts on them going forward is enormous. It's not recognised by agencies doing intervention, particularly. We have concerns about their journey through the justice system. The criminal justice system in Queensland is slow, it's trauma-inducing, but for women with a head injury, it's awful. It may take 2 years to get a final outcome for a strangulation case. And along the way, no one is recognising this as a woman with a brain injury. Last year, Tanya and I had the privilege of attending a conference in Sydney hosted by Brain Injury Australia, and that's where we first heard of Rachel doing her wonderful workshop in Sydney. And we thought, yes, we've got to do this. We've got to do more of this. We've got to keep putting it out there so that people can actually start to recognise through mediums like the Brain Injury Institute, the Stroke Foundation, that we go well outside of our known knowledge as it is now about domestic violence and step into that space of brain injury. So thank you all for joining us. We're very excited to have all our presenters here with us and the generosity of their time. It will be a rich discussion, a rich webinar that we're proud to host. But I just want to put that warning out there that this also comes with we're dealing with something really serious, and we know that domestic violence impacts on all of us. So please, if there's something about the presentation that impacts on you, feel okay to step away, have a chat to some of your colleagues, or seek support. We don't want anyone re-traumatised by what we're presenting. But without further ado, our first presenter that I'm going to be introducing is Rachel. Rachel's an energised speaker. We love her presentations. She's from the Ohio State Domestic Violence Network. But Rachel, I love the terminology, and we're adopting it, partner inflicted brain injury. And I think that that actually tells us very, very succinctly what we're talking about. It's not a brain injury that women are getting from some unknown source. It's inflicted by their partner. And we need to actually, I think, address this a whole lot more and recognise the dangers of strangulation particularly. Rachel, we've had a homicide here in the last few weeks in Queensland, and there was 3 that we know of, 3 prior strangulation reports prior to her death. We need to do more to take it seriously. So please give a warm welcome to Rachel. She'll be able to explain a lot better than I am of what she does, but we love her work. Thank you, Rachel.
Well, thank you so much for having me. I really feel very honored to be talking to you all, in Australia, to be talking to you all in the future. As I said, it's 7 p.m. on Tuesday, so I hope that the future is going well and that you all are doing well. And thank you so much for starting your day and taking time out to do this. I know everybody is very busy, and I don't take for granted you all being invested in learning more about this. And appreciate the opportunity to share a little bit of what I've learned and what I think is such a critical issue and a critical topic for anybody who works with domestic violence survivors. Betty, as I was listening to your introduction, I was thinking a lot about when we're talking about homicides that are happening in Australia, we're talking about homicides that are happening here in the United States, and the connection with strangulation, the connection with pretty severe and brutal violence, the connection with head trauma. But, I think one of the things that has happened is my organization, the Ohio Domestic Violence Network, and just give you a quick snippet about what we do. We're a statewide organization in Ohio. We have 76 local domestic violence member programs who provide direct services to domestic violence victims. And one of the things that, we kind of fell into this brain injury work kind of by accident 6 or 7 years ago when we wrote a grant on increasing access to domestic violence programs. How do we make our programs and work more accessible for people who have disabilities? And we wrote that around mental health, because anybody who works with domestic violence or has experience knows that sometimes it's really hard and just is always a challenge to be able to provide those effective, empowering, and supportive services to survivors who are struggling with severe mental illness. And then we threw in this little piece called brain injury, not because of anything that. It was actually because something that we didn't know a lot about. We had never provided any kind of training. Even myself, as somebody who had been at an organization, had 15 years in doing pretty exclusive domestic violence work, is a piece that I had never thought about, never identified. But what I'm going to do just to get us started, and we'll be talking about, as you said, Betty, kind of where this concept of partner inflicted brain injury came from, which was not mine, but was something that we, as we were looking around and trying to figure this out, was something that I feel like really, really reflected that. And we'll talk about that in just a couple of minutes. But I think what I'm going to get us started with, I'm actually going to share a different screen and just share a quick 3-minute video about some of our original work. What we did is we got this grant, and we were like, all right, I guess we have to go and figure out this whole brain injury piece now. We honestly didn't have any idea what the implications were going to be of this. And we partnered with 5 of our local programs who provide domestic violence services. We went and talked to the agencies and the staff who worked at these programs. We went and talked to survivors who were accessing these services. And I'm just going to share this 3 minutes of kind of what we learned in our research that helped us prepare how we were going to really develop an approach to making sure that our services, our domestic violence services, were taken into account. We're taking brain injury to account, in that our services were accessible to people who were struggling with symptoms of brain injury, both the short-term and the long-term impact. So I'll share this very quickly, and then we'll go from there.
You hear people talk about evil in someone's eyes, like he looked through me like I wasn't even there. And I remember him putting his hands around my throat and like thinking like, I'm going to die.
When we think about the first picture of a domestic violence victim, the kind of classic iconic image of a battered woman is a woman with a black eye, right? Which one of the things that I realized now in the context of this work is she very well could have had a concussion in the context of that black eye, but it is something that none of us in the field have thought about.
And I don't remember much after that, but a nosy neighbor saved my life. Like somebody had heard all the stuff going on and knocked on the door, and that was the only reason I'm still alive.
And how we hadn't, it's one of those things you say it, you look at the data, we talk about brain injury and hits to the head, and it becomes very obvious very quickly. But even in my role at my organization as a statewide leader, having led a trauma-informed initiative across the state, trained in other states about the work that I was doing, never once had I mentioned brain injury. And how did we manage to miss that?
81% had reported being hit in the head. 50% or so many times that they couldn't remember. And 83% of the survivors working with the organizations reported that they had been choked or strangled so that their brains had been deprived of oxygen.
And the sad part for me is I'm an EMS educator. Like I teach trauma. That's like one of the things I love. And yet, even though as much as I know about trauma, I totally missed the strangulation part, the brain, and the effects that it's had on my body.
Many survivors who have been living with unmet need regarding brain injury intervention for a long time do end up developing comorbid issues like mental health issues and substance use issues, struggles with suicide. So unless we're identifying the underlying brain injury early, there can be other long-term health impacts for survivors of domestic violence who are not receiving the services that they need.
At one point, I attempted suicide. And so it was like, if they would have found this earlier, like, you know, my family has watched, and my friends and family have watched me, you know, try to end my own life and stuff. And it's like, that all could have been avoided had the right people had the right knowledge.
This has just kind of changed how we think about things and how we want to do things. And we're very, very hungry for helping us tackle this, because this really hasn't been tackled in this way before, and helping us from a practice level figure out what this needs to look like in the very complicated, very challenging work that domestic violence agencies do.
So, oh, hold on, let me get myself, I'm going to get back to my slides. Sorry, my computer's acting a little funky over here. But, you know, I think as we said, and I don't know, I think that I'm, and anybody feel free to put, you know, any kind of questions or comments in the chat box. I know we talked about that earlier, but I think, you know, the big takeaway from me of that was really thinking about when we went in and talked to, oh, let me get myself back on camera, I'm sorry. We went in and we went back and talked to programs and talked to survivors. It was just such an enormous role, that an enormous amount of head injury that individuals were experiencing. So this is just a little bit. So again, we went in there, we had 49 different survivors we did in-depth interviews with. And when we asked, have you ever been hit or hurt in the head, 86% of the survivors who are accessing our services said yes. With 49%, when we asked how often you've been hit or hurt in the head, 49% said too many times to count, said I couldn't even put, turn that down, please. Sorry. I couldn't even put a number on it. I couldn't even tell you how many times I've been hit and hurt in the head. The same survivors that we were talking to. And I think that this is one of the things when we think about strangulation, we think about strangulation and lethality. We know strangulation is absolutely connected to lethality. It's absolutely connected to increased risk for danger. It's absolutely connected to increased risk of homicide. But one of the things that we were realizing is also almost all of these survivors who are in our shelter, who were alive, who the vast majority of them would not be killed by their partners, had pretty severe strangulation histories, along with head trauma histories. And the odds that these people would continue to be impacted, and it would get to the point where some of their head trauma, which was going almost wholly unrecognized and undiagnosed and unidentified by both people who were helping them and survivors themselves, that this was playing an enormous role in their life, weeks, months, years later. And it was something, and then, that's what we did. And we were just like, even myself, being somebody who had worked in domestic violence for a decade and a half. I always say I'm a domestic violence nerd. I know that sounds strange, but it's, I love it. I can't imagine doing anything else. And I read stuff about it all the time, and I talk about it all the time, and I think about it all the time. But even someone like me, whose job is to be on the cutting edge and what are the things that we're talking about, had never considered this. And so I think that that's, and that was kind of, and I'll go on, but that was kind of the juxtaposition of, we were saying we had almost everybody we were working with had pretty extensive head trauma history. And then when we went and we talked to service providers, we talked to people who were working in DV services and asked, what do you know about brain injury? They didn't know anything, and had never really considered it an issue that was impacting the people that they work with, and that was impacting the survivors' health, that was impacting the survivors' activities of daily living, just their day-to-day lives, but also was impacting them within our services, was impacting their ability. I know Betty talked about the criminal justice system and participating in that often very, very difficult process, but I feel like almost an impossible process if you're also dealing with an unidentified and unaddressed and unaccommodated for brain injury, where people were not being successful in our services, or not getting what they needed out of our services, or not even being able to get into our services because of some of those impacts of brain injuries. So it was just a real game changer to us. And it was, I think that as I said in the video, I spent many years leading a trauma-informed initiative around the state, did that without any recognition of brain injury at all. And the 150 pages that we developed and wrote our toolkit around trauma-informed approaches, brain injury is not mentioned once in there. And it just was like, I really do think for those of us who provide domestic violence specific services, when we talk about our services, we have domestic violence in our name, or that's a part of our mission, or wherever that is, there is an incredibly high likelihood that people have experienced head trauma. And if they haven't, they're at incredibly high risk for experiencing it in the future. I think the other thing is, we got to one of the other things that we did in our project was we really wanted to start building relationships in the brain injury world. And I know Betty talked about the Stroke Foundation and all of these other people who work with brain injury. And we literally didn't know anybody in that world, didn't know who did that, didn't know what brain injury services look like. But I think one of the things that we realized, and we'll talk about kind of how this concept of partner inflicted brain injury came to be, is we started to think about and learn a little bit more about some of the approaches related to medical conditions such as stroke, related to brain injury, related to accident prevention, even the whole idea that most traumatic brain injuries are accidents. People slipping and falling, even sports concussions. Sports concussions usually don't happen on purpose. Somebody's not trying to give you a concussion as a part of your the game that you're playing. We just were really recognizing that this is a whole different animal, that the situations and circumstances of domestic violence survivors and all of the other complex issues made a lot of those brain injury protocols and those return to learn protocols for students and those return to play protocols for athletes, like there wasn't really an equivalent for that the domestic violence survivors that we were working with, that there was no translation of what that is and what that looked like. And we could spend this whole webinar talking about like, what are the differences between military concussions and sports concussions and domestic violence concussions? But one of the real realities is we know that brain injury caused by violence are these multiple traumatic insults, multiple traumatic events that are occurring, and that people are trying to heal from these brain injuries in an ongoing traumatic environment. So I think that when we think about psychological trauma and brain injury, in the context of domestic violence and abuse, those are things that cannot be separated. And I know we're going to hear about when we think about the overlap between PTSD and neurological trauma and psychological trauma and what that all looks like. That is a part of the package. And this is it's a different package than people who have been addressing brain injury have been prepared to address. I think that, one of the things is I just did some training for the police just last week, and we were looking at one of the things we want to do for this training was to we just had one of our partners who was going to do the training with me pulled a few police reports. And it was one of those things, I feel like the other thing I could title this training is hidden in plain sight. Kind of like stuff you've known for the entire time you've ever worked with domestic violence. I don't know if anybody here is shocked that there's lots of head injury in domestic violence. That's not new information, but the number of documented police reports. These are police that have had no training on head injury, no special instructions on documentation or any of that. The incredibly high documentation of head trauma, where people are hit in the head, people are thrown to the ground, then people are choked and strangled, then people are hurt and hit, just like even how many times have multiple head insults in a single incident. We don't even have any kind of research. That is not the same thing as a football player or I think in rugby player in Australia, maybe. It's not the same thing. So that's what came us to this kind of conceptualization of partner inflicted brain injury, which is really just recognizing that domestic violence victims, there's again, some of those real differences between sports concussions and military concussions. First of all, we have obviously in domestic violence, it's an overwhelmingly female population, of which, in the United States, one of the biggest source of research on repetitive concussions is professional football. There are no female professional football players. And then again, the intentionality of that, which is a part of the trauma-inducing piece of this brain injury piece. Plus, you have the traumatic brain injuries, the concussions, the blows to the head. And then you have the anoxic and the hypoxic brain injuries, the oxygen deprivation brain injuries. So, when we talk about strangulation, and this is as we were getting to, meeting with people who do concussion work and in sports, and we started mentioning strangulation, and they looked at us like a deer in the headlights. Because of course, if you've worked with high school athletes, you've not worked with a lot of people that have been strangled. But it really is this idea is about when a person's brain is hurt through intentional strangulation and or blows to the head by their partner, which can cause a traumatic brain injury, concussion, or other type of brain injury. Now, Dr. DeBose is going to talk a little bit more about some of the medical piece, after this, really thinking about like there's no super solid understanding of definition of what this all looks like and what the diagnosis is, but this is just a different animal. Even again, how when a brain is hurt and deprived of oxygen, what is it that looks like? So I'm going to real quickly just take a couple of minutes to talk about, like, you know, again, when we talk about a traumatic brain injury, concussion, mild traumatic brain injury, another term for concussion. There was really some movement about, like, should mild even be a classification of a traumatic brain injury, because there really isn't like a mild brain injury. That doesn't really exist. Just like I would say that really isn't like minor violence or mild violence, but it's really a clinical diagnosis which involves some kind of external force to the head and disrupted brain function. When we think about how commonly, when we talk about what this disrupted brain function looks like, the loss of consciousness, which we know that often survivors are unsure if they lost consciousness. It's one of those things that we often are, you know what I mean? Like, it's not something that you're always totally aware of. The lack of memory or loss of a memory immediately before or after the incident. We think about the tremendous implications that has on things like criminal justice systems. And so many of our systems that depend on people being able to tell us the who, what, where, when, why, how. And being able to tell us that in a very concise, very exact, very consistent story. That's not how a brain injury happens. Any alteration in mental state, dazed, disoriented, confused. I just go back and think of the number of domestic violence survivors that I worked with who are probably healing from an acute concussion and were dazed, disoriented, and confused. And that was something I didn't even recognize. And I didn't consider how I needed to be working with the survivors differently, or how I needed to be adjusting my services in order, how we needed to be timing when we're doing things, what paperwork needed to look like, how maybe we needed to be talking about some, you know, kind of medical care, or even just thinking about how one of the things that we don't want to do after somebody who has had a recent head injury is make them think really hard about a bunch of things. Even those visual disturbances that were temporary or permanent, people aren't seeing things correctly. It's not, you know, that's not what it's that their vision is off, their eyesight is off. And these are kind of things, again, particularly some of these things, there is absolutely an overlap between some of those trauma symptoms and some of those brain injury symptoms. But like I said, once somebody's hit or hurt in the head, they've just had an incredibly psychologically traumatic incident where they were they had neurological trauma that occurred, and both of those things are happening and can't be separated out. So, you know, I think the other thing is we've learned more about traumatic brain injury, concussion, really just recognizing how complex it is. I actually was just calling today my daughter. I have a 15-year-old, and she hurt her ankle playing volleyball, and I had called to make her an appointment for physical therapy. And I was calling our medical provider and was on the hold where they're like, to connect to blah 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 blah, and it was to connect to physical therapy, speech therapy, occupational therapy, or the complex concussion clinic. Press one. Again, a complex concussion clinic has anything to do with domestic violence as of right now, but recognizing how complicated and complex concussions can be, even in the best of situations, even when they're identified early, even when people have access to medical care, even when people are living, you know, at a situation in their life where they might be able to take some brain rest, might be able to take some time off. They're very, very complicated. That's just what brain injuries are. And I think that that's something for us that's very, very important for us to acknowledge. But what happens again is that our brain tissue stretches, pulls, and damages tissue, which can cause widespread damage. And those neurons, those brain cells cannot regrow, but slowly form new connections. Something that is so interesting when talking about working with the brain injury, we've gotten very, very close and very, very well connected with the brain injury world here in Ohio. But it's been something that so many people have said, you know, when you've seen one brain injury, you've seen one brain injury, which means they can manifest themselves very, very differently, that each person that we work with is going to have their own unique situation, their own unique considerations, their own unique healing path, their own unique needs, and what those are. There isn't, you know, people like to ask, like, how long does it take to heal from a brain injury? Well, it just depends. It depends on so many different things. But, you know, I think The other piece is that's a little bit different when we talk about working with this partner inflicted brain injury. When you're having a brain injury that is intentionally caused by violence, it is one piece of a very messy puzzle. And we have to be looking at the puzzle. We have to be looking at the overlap between some of the other physical health issues that are often neglected and people don't have access, some of the behavioral and mental health issues, some of the issues related to social determinants of health, related to even access to services, access to transportation, access to childcare, access to being able, we have a very complicated and very messed up medical system here in the United States, but just those access pieces. And we cannot treat and figure out what an approach looks like to addressing these brain injuries without acknowledging that. As far as strangulation, we know it also causes a brain injury and it has significant safety and lethality risks, but also significant risk of long-term health consequences, including disabilities. And I think that that's the piece is, yes, it is, when we talk about it can cause lethal violence, but there are hundreds of thousands, if not millions of women whose day-to-day lives are being affected by their strangulation that happened in the past. We know it causes damage very fast. There's almost always co-occurring head trauma, where people are having their head slammed against the wall or the floor, or being hit in the head and then strangled. But we know that there's a whole host of reasons why these brain injuries are minimized. They get minimized, including people are unsure about what happened. There's very, very likely that there's not visible injuries or not serious visible injuries. People don't have access to care. Nobody asks about it. It happens a lot. So this, again, that gets minimized and these brain injuries go undetected. I got my warning. I only have I didn't want to tell you when I think it was 7 hours that I did. I have just a couple more minutes, but I'm just going to, now kind of, I've got 3 or 4 more slides and then I'll be done. And looking forward to hearing our other presenters. But we also need to recognize that those of us as service providers, we're dealing with a couple of different things. We could be dealing with acute head trauma and strangulation, where somebody's coming into us and might have had some type of head injury within the last 2, 4, 12, 24, 48 hours, and what that looks like. We're also dealing with chronic head trauma and strangulation, where someone maybe has not been recently hurt, but their history of repetitive head injuries is really, really affecting their ability to function. It's really affecting their thinking and their planning and their organizing and their thought processes and their follow through and their prioritizing. It's affecting their health. It's affecting how they feel. It's affecting their mental health and their emotional control. So those are both things that we are dealing with when addressing domestic violence. We did develop in the Ohio an approach, an evidence-based approach. We do have a couple of recently published journal articles that I will make sure you all get my email address and I can email them to you. We are not allowed to publish them on our website because of copyright issues, but this approach is called CARE, and CARE really is around connecting and building relationships and trust with survivors. We have to make sure that those of us who are working with domestic violence victims are really providing information and education. We're acknowledging that head trauma is common. We're telling people that head trauma and strangulation can cause a brain injury. We're not diagnosing a brain injury, obviously, because that is a medical condition that only a doctor can do. But we are helping raise awareness on this connection between how being hit in the head can hurt your brain and how that can impact your daily life. We're responding by accommodating those needs, by thinking about how are we providing services in a different way? What is it that looks like? How are we adjusting how we're providing your services to take into account your considerations, some of the functional limitations you may have? If you're having problems with memories, how are we helping remind you of things in a different way? We're also thinking about where are those relationships and what are those accessible referrals that we need to make to behavioral health care that's brain injury informed, to medical care, to other types of housing and what those services look like. And then we're evaluating, we're checking back in with survivors. We have a feedback loop that really helps us adjust and shift course and change. And when things don't work, thinking of new ideas. and again, talking about the framework of care really being based around accommodations, which is providing support in a way that takes into account a person's unique needs. As far as slides, I know somebody asked about slides. I will make sure to provide those, and you can absolutely have these. But what the accommodations do, and I've just got another minute, is really provide support in a way that takes into account a person's unique needs. So again, if we're talking about somebody who's having a hard time focusing and paying attention, how are we meeting with them in a different way? How are we meeting with them in a space that has less distractions? How are we maybe having shorter meetings? If someone's having problems with comprehension and recall, how are we checking in with them and having them share back with us what they understood? How are we explaining ourselves in different ways in more than one time? We also have, as I'm going to show you our care tools real quick. These are all different educational and service provision tools that we've developed that are available on our website for free. And I will show you where those are in just a second. They're available in English and Spanish for you to download. I would highly encourage you to look at them. Another new tool that we have developed is just a simple card. I wish I left it there. Let me see if I have one right here in my suitcase. I just got back from a training, so it's just a little card like this. I'm sorry, it has that says, sorry, I have a blur. Being choked or strangled or hurt in the head can cause a brain injury. And this was actually inspired by some of the work done in Australia that says getting help can save your life, and it's got a QR code on the back that links you directly to a website with more information about head injury and strangulation hurts your brain that domestic violence survivors can go directly to. Care has been evaluated and it improves trauma-informed practices. And really the last thing I'm going to do, if it's okay, I'm just going to take you real quick and show you where that website is, just so, and I'll put I don't know if people can see, I can know if I can put a link in the chat box. I don't know if I have access to do that, but I'll just show you that real quick. And then we will transition over to our next speaker. I'm going to share my screen very quickly, but if you go to odvn.org, oh, sorry, share, let me hit share. If you go to odvn.org, which is our website, which is the Ohio Domestic Violence Network, and you click right here on our work, you'll see brain injury right here at the top. We'll take you directly to our webpage where you have the video that we saw earlier. Here's some of our care materials, our educational materials, as well as our service providers materials, including e-learning course and online learning course that's free. This is our webpage for brain injury survivors, and there's lots of really good information here that I would highly encourage you to check out. I will make sure, the last thing I'm going to do is just make sure I share my contact information. So it's so hard for me to talk about this in a half hour, but my email address is rachel.r@odvn.org. We'll make sure to get you a copy of the slides and all of this information, but I really appreciate you all being here. And like I said, I will be off camera for a little bit, but I will be hanging out to hear the rest of the presentation. And thank you so much, Betty and the Red Rose Foundation, for having me.
Thank you, Rachel. Are we right? Need to pull up the rest of it. Are you able to close that down? Thanks, Rachel. Yep, thank you. That's wonderful. So thank you to Rachel. And we could listen to you all day. And we're looking to hold a national strangulation conference at the end of the year. So you'll certainly be hearing from us for a bit more, Rachel. But hang around, as you said. Our next presenter is, both our presenters now, three presenters are from Queensland, from the Gold Coast all the way to Palm Island. But we're hearing next from Dr. Julia DeBoss. Julia has worked in emergency medicine for quite a while, from Townsville right across to Mount Isa. Doing emergency medicine and emergency medicine training. She's now also on the Gold Coast as a forensic medical officer. Julia has written about strangulation. She trains on it. She has trained with us at the Red Rose Foundation. And, you know, it's a great privilege, Julia, to have you join us, and I welcome you as well. Are you able to pull up your...
Yes.
Yeah, we're here. Thank you, Julian. Good morning.
Thank you. G'day, everybody. My name's Julia. As Betty just said, I'm an emergency physician. Predominantly, I'm going to be speaking to you with my regional hat on. Mount Isa is a tiny little town under the Gulf of Carpentaria that is maybe 25,000 big, but has a lot of mines, stations, remote Indigenous communities around it. It's a totally different world to where I also work in the Gold Coast, which is a large urban centre. So we're going to be talking about brain injury, but from a regional perspective as well. I'm just going to share my screen. Okay, hopefully you can now see that.
Yep, Julia, we can see it fine.
Just hitting play. All right. So I want you to imagine you feel concussed. You have been strangled or hit to the head. Both of them can cause a feeling that feels like concussion. You have a headache. You really can't think properly, but you can some of the time. And then other times you go to think of something that you'd usually be able to think of quite readily and easily, but you can't bring it to mind. And you can't predict when that's going to happen. What you really want to do is get out of there. You don't know necessarily where you want to go, but that feeling of I've got to leave is at times overwhelming. You're mildly nauseated. What you really want is everybody to just leave you alone. You need a cup of tea. You need to lie down because you feel dreadful. But you're in a crowded waiting room at the nearest emergency department, and it's likely that you're going to be in that waiting room for 2.5 hours. Now, once you've been moved into a cubicle, you're still looking after 2 kids and 3 grandkids. They're now bored. They're running around your cubicle. The police want your statement now. They're under the pump because there's been some football games and they're getting calls left, right and centre. You think, well, a friend lost her children when she couldn't leave her abuser. And you're looking at your 2 kids and your 3 grandkids thinking, I just can't lose them. You know that there's a DVO against both you and your partner, and you've just been assaulted and you're not really sure if you're in trouble because the assault is proof that you were together. The ED is noisy. The noise hurts your head. And you've been here before. You've had CTs in the past. A CT in the past doesn't seem to have ever really made a difference to what happened next. You've heard they can cause cancer. And your last CT was only 7 weeks ago and you can't go home. It's really, really difficult to negotiate emergency departments, especially when you've got kids and grandkids that you need to care for on a good day. But it's much, much harder trying to navigate the criminal justice system when you've effectively got what seems like a concussion. A lot of people just can't do it. Okay, they try, they come, they can't wait. And the vast majority of people sustaining brain injuries don't come to us straight away. Some do. Mount Isa is, from an emergency department, Mount Isa feels like it's awash with alcohol. But sometimes having met people before in the context of alcohol also means they know us and they're a little bit, I suspect, more likely to come back if they know us. Sometimes it feels like the alcohol gave people the courage to come to an emergency department and say what's been happening to them. It's challenging. Now, we all know the stats. Intimate partner violence and family violence, this is from one of the national surveys. Since 15 years old, 1 in 4 women, 1 in 8 men will have experienced violence by an intimate partner or family member. In terms of sexual violence, it's 1 in 5 women, 1 in 16 men. But it's not all men and all women necessarily equally. Strangulation is a crime that's about power. And so situations where the power differential is, should we just say larger, can make you far more likely to be strangled and also, unfortunately, feel less capable of getting help when you are. So, for example, 24% of Aboriginal and Torres Strait Islander women who are also living with a disability or a long-term health condition, which is a lot of people, experienced violence between 2014 and 2015. So we're not talking about lifetime prevalence since you're 15 anymore. We're saying in that year, how many people experienced violence? And it was a quarter. When women experiencing intimate partner violence, up to 90% will incur injuries to their head, as you've heard. And of those experiencing strangulation, less than 3% will eventually present to an emergency department or a GP. The vast majority of these people stay at home. So, some medicine, strangulation and neurological outcomes or impacts on the brain. We all know from sport and media about concussions, and I'll come back to that feeling of concussion because from a patient point of view, it feels often the same. There are neurological consequences like loss of consciousness, mild traumatic brain injury, strokes, seizures, difficulty speaking or moving. Psychological outcomes can include post-traumatic stress disorder, depression, feeling suicidal, dissociation. There's also cognitive, which means thinking, and behavioural consequences. When the blood or the oxygen is cut off to the brain, you stop making memories. So amnesia, particularly the event, is extremely common. And by compliance, I mean that people can go into what seems like a pacification behaviour, particularly if they've been in a situation long term. So basically everything they're doing is about pacifying the person who inflicted that injury in a desperate attempt to feel safe. So that might mean people get isolated in the house. It can mean that they'll say anything other than that it's domestic violence. It can mean that they're more likely to say yes to anything that family asks them, including, will you leave the hospital now? It can be really hard. And at the same time, if you remember my first few slides, the noise is probably hurting their head. They might be struggling with light. They might be feeling nauseated, have a big headache, and just generally feeling like they've got to run. So we're in a regional centre and we go to the ED. In the perfect world where reports are always written, everybody meets their targets, people are seen on time, there is a very large role for the ED in this ideal world. It's our job to support the disclosure of the victim, to recognise the red flags, not just for head injuries in sport, head injuries in car accidents, but head injuries in domestic violence. We need to recognise that while common, domestic, family and sexual violence isn't normal, and find effective ways to communicate that without making somebody feel shamed. Encouraging self-esteem and establishing that rapport is everything. We need to diagnose and stabilise whatever injuries we find, make appropriate referrals on solid pathways to additional care such as concussion clinics that work. We need to have a team approach with our domestic violence specialist agencies. We need to expertly document, produce statements and go to court with the victims if necessary. But we don't live in an ideal world. We've never lived in an ideal world. We do this in an environment where the waiting room is small, loud, bright, that everything feels rushed, where queues can be, in Mount Isa, they're not too bad, but if you go to some of our inner city hospitals, they might be 8 hours or more. Our red flags in Australia, the vast majority of emergency medicine is initiated by junior doctors who then speak to a more senior and then a more senior, depending on what they find. So supporting disclosures and the sort of the art of medicine might not have been strongly established in the person you meet. Diagnoses, I'll come back to this, but it's a lot more complicated than you might think. Appropriate referrals. Unless you're living in a capital of a state or a very large regional centre, there's almost no concussion clinics in Australia. Access to assistance such as occupational therapy, neuropsychs is very difficult to obtain. Our domestic violence specialist agencies are under the pump. We're under the pump, they're under the pump. Hopefully we all get documentation going well. So we have a very large role to play, but we don't live in an ideal world. And brain injury disclosures, they have difficulties before the patient ever arrives with us. So what sort of barriers happen from, in our experience, from real world people coming to a real world ED? Before anybody opens their mouth, in my region, the biggest fear will be that they're worrying about losing their kids and possibly their grandkids, and there's a strong mistrust of authority. And the trouble is, that's for valid reasons. People can lose their children if they're being asked by the system to choose between staying with an domestic abuser and staying with their kids, because we recognise that exposure to domestic violence is a form of child abuse. To somebody whose whole life has been about the pacification of somebody else, who's neglected their own needs, potentially lifelong, if they've gone from domestic violence to domestic violence situation, asking somebody to leave their abuser and putting all the responsibility at the end seems like an absolutely impossible choice. So people do lose access to their kids. There can be very strong feelings of shame. In my region, we have a large proportion of Indigenous women, and they talk about not wanting to perpetrate stereotypes, particularly if the doctor feels a little bit fresh to the region. They might not want the perpetrator incarcerated. Within Queensland, we have very high rates of particularly Indigenous people in custody. There's family and societal pressure of not breaking up the families, not wanting to basically rock the boat. And we're talking about people whose impulse to not rock the boat may be very strong. And then there's simply exhaustion in the ED environment. So that's before the doctor ever opens their mouth. There's all sorts of barriers that are reasonable. When we're talking about training within emergency departments, the only tool that is really recognised both by the evidence and by the College for Emergency Medicine is what we call a HITS tool. HITS means, has anybody hit, intimidated, threatened or screamed at you in the last little while, 3 months? If they say no, you just write down HITS negative. If somebody says yes, then you sit down and you have a conversation. And there is a surprising number of victims that we find in police watch houses coming for basically fitness for custody assessments. When, particularly in our region, people fight back, as they should, be perfectly honest, as they should. And so when somebody first goes to a scene, police officer or whoever has interrupted, neighbours, whoever, the scene seems crazy. You know, there's been this event, his family's blaming her family's blaming him. It's all chaos. And if you just go into that chaos and make a snap judgment, you're going to miss the power dynamics that's been occurring in the relationship for a while. And that's where we depend on our domestic violence specialist agencies to come behind us and say, look, well, it's a little bit more complicated than that. These are the controlling behaviours that have been going on. This is how the coercion is occurring. What can we do within the ED? The first is to respect the courage, of course. It takes so much courage for somebody to come forward and say, I've been strangled, I've been hit to the head, and the domestic violence has been going on a while. Rapport is everything, and that is helped by active listening, acknowledging the complexity of the situation and validating their concerns, not by giving your opinions, giving your experiences. Interestingly, if you take an ED doctor and you walk to the bed and you preside this many seconds of care, if you sit while you're providing that care, the patient can, to the patient, when they say how much did the doctor spend time with you, they'll actually remember it as longer care than if you stood next to the bed and just took the history that way. Providing practical information is obviously important, but it's about facilitating the decision-making of the patient rather than telling them what to do, which can come across as being the next coercive person rather than an ally. Of course, within the ED, we want to recognise lethal risk factors. Now, this list of risk factors is the one that we apply in my region. They can vary between regions, but number 2 is non-fatal strangulation. If undergoing separation, threats to kill, history of escalating DV, perpetrator having access to weapons, and we have the highest rate of gun ownership in the country, although it's significantly less than the United States. The abuse of pets, isolation, perpetrators attempting suicide, non-compliance with court orders, pregnancies, new births, and if the victim says it's getting worse, it's getting worse. You're done. Recognising lethal risk factors opens up usually other pathways, such as high-risk domestic violence teams that can come behind the ED or behind the GP or whoever's taking this history and provide extra assistance and extra options. So let's talk about brain injury specifically. Firstly, although everybody thinks they know what it is, there's actually no real agreed definitions. Almost all of the research has been done based in sport because sporting codes is where the money is. What that means is that when people have taken, just say you go back and you find 100 patients with a brain injury and you're looking for common factors to know when to CT, when to bring to hospitals, all of those sort of things. Because that's all based on sport and motor vehicle accidents, there essentially are no evidence-based guidelines which say these things lead to this outcome. It's very much within the Australian system based around looking for structural damage, and the way we categorise mild, medium, severe tends to be looking for things like bleeding, skull fractures, facial fractures, and when somebody's got an extreme brain injury, we're pretty good at picking it up. The search for the concussed brain or the structurally normal brain that's not functioning properly is actually much harder than you'd think it would be. We have issues around imaging because a structurally normal brain looks normal on CT. If you can have a brain that's barely functioning at all, but if it's structurally normal, your CT or your MRI will usually be normal. And these are the people that are sort of, you look at them, they don't look too bad, so they've got an extra long wait in the waiting room. The cubicle is more likely to be in an area in the ED which is devoted to high flow, rather than being moved into, say, the resuscitation bay, where it's expected that the patient will take longer if the triage nurse looks at the person and says, oh, I think you've got a very severe a brain injury. So that's why I'm going to start looking from here at mild brain injuries, because these are the ones that are missed. We have, because brain injuries in domestic violence tend to be a recurrent fare, we have issues around even imaging in terms of radiation load. In Australia, there's no cost to someone presenting to emergency department and getting whatever imaging they need. There's a cost if you go in the private system, but people predominantly go to the public system. But how often are you going to CT? So somebody's come for, just let's say somebody's come for a strangulation and you're considering CTing their neck. A recent, the physics were broken down basically recently at the Gold Coast, and it's an estimated 1 in 3,000 people who are at risk of an additional cancer because of those sort of CTs. So the risk of that first CT is not high, but when you start CTing over and over, we start to worry about the radiation load. So what does over and over mean? Does it mean that you CT them once a year? What about our patients that present every 2 weeks? What about, and along with the question of CT, because we're in a regional area with people scattered throughout our region, how often are we going to fly them in? When a patient says, oh, I've had 15 CTs and I've been flown in for all of them and none of it ever makes a difference, they might have a point. It might not have made a difference to that point. So are we looking for severe brain injury here, mild brain injury? What are the monitoring options? Can we keep somebody in what we call a short stay unit and watch them? Depends on space, depends on where they are. So all of these images, all of these issues around how often do we scan, when do we monitor, how long do we monitor, when do we fly out? None of these have been answered with science. They've been answered with strong opinions, and the strong opinions change depending on who you talk to. So if you've got a severe injury, we're likely to pick you up. But those mild ones who are desperate to go home, they're the ones we're missing. Now, confounders. When you look at somebody who's okay, their brain's not working great, but they're really drunk, or they've had other drugs, or they've had various other issues in their lives, seeing what is temporary, what is permanent is essentially not possible. But defining what is there because of the injury and what is there because of the confounder is difficult. So let's talk about some of those symptoms and how hard it is to pick them up. So these are critical signs of things likely to cause a severe brain injury, and we pick these up. Severe neck pain, increasing confusion, agitation, recurrent vomiting, seizures, weakness in the arms or the legs, deteriorating levels of consciousness, severe and increasing headaches, unusual behavioural change in somebody that we have an idea of what they're usually like, and double vision. Okay, we call these critical signs. But then we get to what might be known as obvious signs. So a loss of consciousness that has resolved. No protective action reported by witnesses. Unfortunately, domestic and family violence is not usually surrounded by witnesses. Seizures or jerky movements after the knock to the head or the strangulation. Again, the person who did the strangling is not necessarily the most reliable witness. Confusion or disorientation at the scene, but that is resolved in the ED. Memory impairment. It is essentially like it's almost impossible to say my memory is fine because you can't remember what you forgot. Being unsteady on someone's feet or balance. Please remember that we see people lying down on a trolley most of the time. So getting them up to walk is important. Or that they're looking dazed or looking blank, looking vacant. Well, given they've just been through what they've been through, that's not necessarily a surprise. The signs can get more subtle. A not so severe headache, a feeling of pressure in the head, nausea without vomiting, dizziness without falling, blurred vision. Do they have their glasses? Balance problems, but they're able to walk, so they feel not quite right, or they might have balance problems that you'll only notice if you get them to stand on one leg. Sensitivity to light and noise, feeling slowed down or feeling like a fog. Often a patient won't volunteer that unless basically you specifically ask, because we're talking about patients that will still probably be blaming themselves for the incident. Very subtle signs. I just don't feel right. I can't concentrate properly. I'm having trouble remembering. I'm tired. I just want to lie down. Confusion that might be subtle. Drowsiness, they might be a bit more emotional. They might be irritable, sad, nervous or anxious. So with these, you can see that there's a huge amount of overlap between what could be a neurological injury and might just be, I say just, might also be just trauma from the incident. They've just had a horrific response from somebody that was supposed to care about them. And that would throw anybody off their game.
Just a couple of minutes. Thanks.
Okay. The brain must have time to heal before the next incident. Unfortunately, we can't say to a domestic violence, we can say to somebody, don't play sport. We can say to somebody, don't drive. We can't tell somebody in a DV situation, don't get hit in the head again. It's just not possible. We can provide alternatives, but it's something that they've got to step to. There's a large amount of intersection with mental health and substance use. So if you're looking at treating brain injury, you have to address the other things as well. There's a triad that we don't really want to miss: a concussive syndrome, depression, and a post-traumatic stress reaction. That if we see that triad together, we're looking at someone who's going to have issues predominantly for the long term. Access to neuropsychologists, mental health and OTs outside capitals is really hard. So when I spoke about pathways that work, our nearest tertiary referral centre is 950 kilometres away on the other side of the state, and we want to send somebody there when what they really need is their support network. It's difficult. There are programs such as Healing Right Way and other long-term support that's been found to be useful, but it's rarely available out in the regions. And we need to allow that some of these people don't know what it is to feel safe. They might have been exposed to domestic violence as children, and then they've gone from relationship to relationship with issues. Teaching somebody that they don't feel quite right when they don't even know what safe feels like is a problem. So given that we don't work in a perfect system, what can we do as individuals today with the people immediately around us? The most important thing is to respect the courage of those who do present. Concentrate on the rapport and brace yourself for a long haul. Junior doctors get burned out by, oh, nothing ever happens anyway. Well, it might not seem like that in the individual consult, but stick enough of these in a row and we might have somebody who's ready to leave, ready to accept other assistance. Don't ask, why don't they leave? Ask the hierarchies why we don't have the resources to dismantle barriers. Recognise that saying, why don't you leave, to a patient can seem a bit judgmental and can reinforce barriers to disclosure. Consider someone's pre-existing radiation exposure and consider alternatives to CT. When considering transfer, we need to acknowledge the need for social support for the patient. Neuropsychological assessment is what we need and we do not have access to. So if you have a way to lobby for us, do so. And push for all domestic violence services. I don't just mean specialist services. I mean police, health, the works, to be brain injury aware and demand pathways to care rather than just accepting that there's nothing we can do. All people will essentially need to see social workers, brain injury follow-up and high-risk DV team. But understand that it's really hard for us to diagnose the subtle injuries. So just because somebody's been to the ED once does not mean by any stretch of the imagination that they are now medically cleared, that they've been given the big tick and their brain is fine. If somebody says to you, you know, that things aren't quite right, send them to their GP, send them back to whatever service they've been to. These are things that people determine over time. It's not something where you can go into a bright ED when you're feeling dreadful and get approved as healthy or told you have a brain injury. It's just harder than that. All right, I can skip my next slide because I'm out of time. Lovely.
Thank you, Julia. Thank you. Wonderful as always, and so appreciative of you giving us that time. Thank you. We're now moving on to co-presenters, and it's wonderful to be able to, Julia, if you can turn your video off and we'll pull up, are you there, Michelle? Dr. Michelle Fitt, yep, and Yasmin Johnson. For time, I'm going to let you introduce yourself, but I want to say a couple of things. And they're currently coming to us from Palm Island, which is wonderful. But I want to say, you know, in terms of the work they're doing in researching brain injury for Indigenous people, but particularly for Indigenous women in domestic violence, is so, so critical. As I said, I sit on the Queensland Domestic Violence Death Review Board. And it's heartbreaking to see the deaths of our First Nation women with so little put into stopping that violence. And we know they're 7 times more likely to be murdered, 36 times more likely to be hospitalised. And the brain injury, I think, for First Nation women is still not talked about, not recognised. So the research you're doing is just so valuable, and I thank you for your work. So I'll hand over to you. We probably will run out of time at the end for questions, but please put them in the Q&A and Tanya will join us to talk through some of those. But thank you for joining us.
Thank you for that introduction, Betty. I'll just share our screen.
Oh, thank you, Betty and the Red Rose Foundation for their acknowledgement. I'll just quickly introduce myself. My name is Yasmin Johnson. I'm a Waggarukabai woman from Dumbarton. My traditional country is Magnetic Island. But I'd also like to acknowledge that we're on Manburra and Bulgaman country of Palm Island. And we've been working here for the past week and speaking to women about our research and getting some great feedback and some wonderful yarnings with the women. So it's been a wonderful opportunity for us to further raise that awareness and education around brain injury for First Nation women.
Thanks, Yasmin. And my name's Michelle Pitts. I live in Barntra, Alice Springs. I've been working as a researcher for the last 13 years, and I started my research in alcohol and public health back in 2010 in Far North Queensland. But we've been working in the TBI space since 2015, and this is probably the most important, or it is the most important piece of work that I've been involved with. We just wanted to share the two pieces of art on the screen as well. One by Shirlene Campbell on the left, and you may know Shirlene from her strong advocacy for speaking up about the violence that women experience and ending violence, and she sits on a number of national boards and committees. And also Michelle on the right-hand side, she's a Torres Strait Islander woman, and I think she beautifully presents the strength and resilience of Aboriginal and Torres Strait Islander women and the place that they have within their families and communities. It's definitely something that we've been hearing from our work. There's a number of acknowledgements as well. So we're working on an ARC project. It's a 3-year study and includes 3 locations. And there's an amazing group of women that contribute to the guidance and the knowledge and support us to do the work that we're doing. And you can see there, there's a number of women on the screen. I want to acknowledge Elaine Wills as well, who's also collecting stories and information from women, hospital staff and service providers.
We'd also like to acknowledge the deep and lasting effects of transgenerational trauma, impacts on our men, women, children, families and communities. We recognise that this has contributed to the disproportionately high rates of domestic and family violence experienced within our communities. We acknowledge the ongoing work of all key stakeholders within our individual communities in their advocacy work for our women and children to live free of trauma and violence. Thank you.
We won't spend too much time on this slide just due to time, but we kind of came from, for this research, we kind of came from a different angle to what Rachel was talking about from the domestic violence angle. So we were working on traumatic brain injury research and kind of really fell into the connection with family violence. So most of the traumatic brain injury research that has been done in this country has been done with non-Indigenous people in big cities. And then essentially services have been developed for that population. And so it's really only been recently that there's been a greater focus of TBI research with Aboriginal and Torres Strait Islander peoples. And what that research is showing, particularly from WA, Queensland and the NT, is that Aboriginal and Torres Strait Islander peoples and women in particular, that connection between TBI and assault. You might also know about the Jamison study back from 2008 that also showed a connection between head injury and assault, particularly for Aboriginal and Torres Strait Islander women. What is, I guess, a significant step is the recognition of TBI within the National Plan to End Violence Against Women and Children that was released at the end of last year. The previous plan didn't make any mention of TBI at all. So it's really important thinking about the national plan in terms of that recognition of including TBI for when services are working with people who experience violence, but also people who use violence as well. We also just want to acknowledge as well that that people of all cultural backgrounds do contribute to the violence that Aboriginal women, Aboriginal and Torres Strait Islander women experience as well. So just a little bit about our research study. We're working in a remote location in the NT, regional location in Queensland and urban New South Wales. There's 4 knowledge holders that we're working with that you can see on the screen there. We have a number of aims for our project. One of them is about identifying the strengths and gaps in healthcare and service support systems. It's been a very much a learning journey for us implementing this study. We thought, given the high rates of the connection between TBI and violence, that people would be interested in participating. But one of the things that we did find, and we have definitely found that, but one of the things that has really stood out to us is that and like the other 2 presenters, Rachel and Julia this morning, have talked about, no service providers really had done any education around TBI. So we found that a lot of services had done education around mental health, disability, FASD, and other education, but nothing around TBI. So to make sure that everybody had the same level of understanding about how the brain works, how it changes as a result of concussion and TBI, and how you support someone with a TBI. We partnered with Synapse Australia. They're a national brain injury organisation, and they ran education with service providers, but also community members of women's groups to talk about this thing, brain injury. So then that gave everybody the language to be able to explain what was happening for women, and services were able to talk about their clients. We won't be able to talk about, as Rachel said, you could be talking all day about the work and the findings of our project. One thing we did want to present this morning was, I guess, talking about the workforce barriers and the personal barriers that can affect access to healthcare for Aboriginal and Torres Strait Islander women. So I'll start off by talking about the workforce barriers, and then Yasmin will move on to talk about the personal barriers. I don't know how to get rid of them. So we completed interviews and discussion groups with services in the Northern Territory and Queensland. We found there was 4 barriers for women being able to access healthcare following a TBI from violence. One of them is the qualities of the workforce. So particularly in remote communities, what we were finding was that staff were often coming from somewhere else, most often on the eastern seaboard, and didn't have that relationship with the community, and flying in, so may stay for 2 weeks and leave and may not come back to that community, or may just be flying in and out. And there was a really high turnover of staff in the remote communities. And then that impacts on the information that women are willing to share if they're able to access that clinic. We also found that in some places clinics aren't open because there is a shortage of staff, and that's particularly happening in the Northern Territory. And so that then leaves women having to drive long distances to be able to travel to access healthcare in another community. And so that's often on an unsealed road, and so that comes with its own set of risks as well. As Julia talked about before about pathways for all head injuries, so women who experience more significant head injuries will be evacuated out of community. They'll be flown to either Adelaide or Darwin if we're talking about the Northern Territory context. But for women who experience those repeated concussions or mild TBI, there isn't that, if they're not flown out of the community, there really isn't any follow-up that we heard that was happening for women to complete follow-up assessments and supports. In terms of lack of neuropsychologists, again, I won't spend too much time on this because I know Julia's already talked about it, but I think from a criminal justice perspective, talking about diagnosis. So one of the complex things with the criminal justice system is that if women, one of the things we've been hearing is more and more women are coming before the court, and lawyers are looking at their medical history and are aware that women have experienced family violence in the long term, but there's not that medical evidence or diagnosis of a TBI to be able to present to the court and include that in consideration in terms of sentencing. Yeah. The complex thing with diagnosis, on the other hand, though, is, and Yasmin would talk about this, and I know Julia touched on it, was diagnosis can also contribute to women having their children removed. And there is some services that are hesitant to have women diagnosed, so it is quite a complex aspect of this story. The final barrier that I wanted to talk about is the knowledge of workforce and pre-screening. So we found that a lot of services talk to us about the different screening tools that they use and found them to be incredibly valuable, but none of them included any questions around traumatic brain injury. And the other aspect of that was the workforce training and knowledge. And so that, as I said before, no staff had done any training around TBI. And we spoke to a range of different services: disability, mental health, family violence, crisis accommodations, also legal and justice services as well. And you can see there that quote at the bottom about police as well also having no training in this space either. So what happens in those situations, from what services told us, is that they don't consider it in the way that they work with women. Often those signs and symptoms that Rachel and Julia have talked about can be misidentified as being long-term drug and alcohol use, some mental health conditions, and what it is very complex, and it may include some of that in a woman's story, but TBI doesn't really seem to be considered in the way that services are delivered and how women are supported. I just wanted to also share with you the impact that not including TBI has within the service systems themselves. So the first quote is from a corrections perspective, and the other is about child safety. And I think these are really important to include, and something that we've heard not just in one location, but in across the 3 locations that we are working, particularly with the child safety system. If women are on particular orders and are given a number of conditions to follow, it can be often quite difficult for women to navigate various instructions and different services and meet those conditions. And you can see there by that quote about, you know, some of the things that Julia touched on with impacts around short-term memory, emotional dysregulation, and that sometimes can be seen by systems when they're not thinking about women's journey with a disability lens, thinking about that actually that may be neglect, where in fact it's actually that women have sustained, and we've talked about this morning, multiple repeated head injuries, and it may be that she's struggling with those symptoms that we've talked about this morning. And just going back to that first quote on the screen about the prison system as well. So the prison system also doesn't necessarily think about the impact of women being victim survivors of violence, and there can be environmental triggers that contribute to women. And you can see there on the screen about punitive responses to, for want of a better word, poor behaviour, where women may be problematic or difficult, or they're showing those emotional dysregulation signs and symptoms. So it's really important for these systems to be recognising that women are victim survivors and have experienced long-term harms and damage to their brain as a result of family violence.
Thank you, Michelle. I wanted to just touch a little bit on the barriers that women that we've spoke to and service providers who we've engaged with as well. So initially, women may fear child removal. So a frequent mentioned explanation for women being reluctant to engage with emergency services, for example, paramedics, as well as the hospital, is fear of child removal by child protection agencies should they report that their head injury resulted from family violence. Women avoided disclosure of violence to minimise the risk of surveillance and contact with child protection authorities. It was common for women to avoid accessing hospitals following a head injury until they determined it was critical and the symptoms were too difficult to manage at home and alone. To navigate these systems without reporting violence, women implemented a range of strategies to minimise either the risk of being reported to child protection agencies or further surveillance by these systems, including providing limited details of healthcare professionals to healthcare professionals, reporting another mechanism in regards to the violence or in regards to the injury that was sustained, and or selecting when it was safest to engage with healthcare professionals. Fear of escalating violence was also present. Community members, group members described the secrecy of violence within families as remaining hidden. Women feared worse repercussions, not just for themselves and their children, but sometimes for their partners if they reported the violence. Women living in a violent relationship reported family violence placed them in at high levels of risk of further family violence. A frequently mentioned sentiment was that some women preferred not to pursue charges against their partners through the court system because they did not want to send their partners to prison. They wanted instead to find a way to maintain their relationship with their partner, but for the violence to stop. This is more the case when they have children. While women related risk retaliation by partners if they exposed to violence through seeking medical treatment, they were also at times actively prevented from doing so by coercive control means. Priorities of other competing demands for women. Within the narratives, women were described as strong and resilient in continuing to maintain and meet the roles and responsibilities they have within their families and communities. This usually related in the needs of their children and other family members as a primary carer. As the following quote illustrates, women who have experienced head injuries from violence usually tended to the needs and priorities of others first. Delivery of outreach services and programs to women and their families outside the major town was valued by community members and service providers as it supported women who would otherwise have struggled to access services in large service centres. In both locations, participants reported that the majority of funding was allocated to services in the major towns, with women living in outlying areas and remote communities having access to limited services. So I'll just further go on to talk about awareness of brain injury. Community services and Aboriginal focused programs share that there is no or little awareness of education and recognition of brain trauma, brain injury from violence or long-term injuries and damage to the brain from violence. Participants compared the lack of awareness of TBI education with increased understanding of other forms of acquired brain injury that have occurred over time due to strong, consistent work by service providers and investment by government. Frequently spoken about was fetal alcohol syndrome, FASD, where information is on social media, campaigns about the effects of development if alcohol is consumed during pregnancy, and pregnancy checks to prevent, identify and diagnose. Community members also recommended wider information of the association between head injury and violence, as well as pathways and referrals for women to access and to seek help.
Just finally, I know we're probably running out of time, but just some of our, this isn't an exhaustive list at all, and we have many other components to the project. But just some of the practical suggestions or recommendations that we have is including high quality content and training for frontline staff about those signs and symptoms of TBI and how, and Julia had a great list in her presentation of those signs and symptoms and how to support somebody to access supports. But we do recognise, particularly in remote areas, that those supports really just, they don't exist, and it's often falls to family members to care and support community members or women. One thing that's come through quite a lot from community members has been prevention, and so including content within the school curriculum, and when we're talking about what healthy relationships look like, including the impacts that can happen when violence occurs in relationships. And it's really important not just to be thinking about frontline staff, and while that is important, it is also important to be thinking about community as well. So having education campaigns on radio, having more information available, particularly in women's groups around TBI. There's been a lot of interest in running education from our side of things in terms of with the research project. In terms of service practice, so including some questions around strangulation and TBI, particularly asking people about loss of consciousness. And it's not necessarily about diagnosis, it's just about finding out about a little bit of information about what impact women, if women have experienced repeated head injuries, and being able to provide some questions around what impact that might have had. But we do also, some of our work that we are finding that there's different levels of insight as well into the experiences and impact, long-term impacts of head injury. One thing that we're strongly asking for and having discussions about is the inclusion of traumatic brain injury in the 715 Aboriginal and Torres Strait Islander health check. That is a chronic conditions health check, but whether there's opportunity to include brain injury within that assessment as a way for GPs and AHPs to be having those conversations, and so there's more recognition of TBI, and it's more of a regular conversation that's happening on an annual basis. And also the importance of, when we're thinking about the child protection system as well, having particular policies in place. So breaking that cycle of punitive and punishment responses to women who are living with the long-term impacts of violence.
Just the service delivery, so reimagining the design and placement of support services to overcome barriers. So social workers and specialist practitioners located traditionally in traditional locations like hospitals, peer support in safe and trusted places like community organisations, and child protection services delivered by community controlled service providers. A really important aspect to consider is funding, and particularly in the Northern Territory, there's a high need around needs-based funding for First Nation women within Northern Territory. Family violence services and housing services and other specialist services need specialists and needs-based funding that could tailor packages and programs to support women in remote, rural and regional communities.
We're needing to wind up, sadly. We could, as you said, we could go all day on this, and it's just so important. And I, thank you, sincerely thank you. And we'll be in touch, and hope you're around for our national conference in October around strangulation and whatever. Could I ask the other presenters to come back on with their videos, please? Just want to, give everyone a congratulations and a huge thank you. And it reminds me of a saying that we have, it's not mine, but, when we know more, we need to be able to do more. And I'm hoping, the richness that you've all brought today is that we improve practice, improve our responses to domestic violence victims. One of the things that continually arose through the death reviews is comments like a victim failed to engage, which is quite a victim blaming statement, and not recognising all of the things going on, but particularly when there's brain injury and they're unable to engage. Look, thank you. Thank you for everyone that has joined. Appreciate it. Please stay in touch with us at the Red Rose Foundation in our work. We are getting this out there. We're training in hospitality departments, virtually anyone that'll have us. But we run a 2-day training on high risk, high harm, locating strangulation in the context of other really high risk behaviours by the aggressor. So thank you, everyone. And we certainly want to hear more from all of you.